Welcome to the deep dive. Today, we're zeroing in on arteriography.
Yes, indeed.
Even with all the amazing progress in less invasive imaging, duplex mapping, CTA, MRA, arteriography still seems to hold its ground. It's considered the gold standard for looking at arteries, right?
Precisely. While those other methods are incredibly valuable and their use is definitely expanding, for vascular surgeons, arteriography often remains indispensable.
Indispensable how?
Well, it offers this unique combination of really detailed visualization and the ability to integrate diagnosis with immediate intervention.
Ah, so you can see the problem and potentially fix it right then and there.
Exactly, which is frequently critical.
Okay, let's unpack this then. Because
Yeah.
when you start thinking about everything involved in doing an arteriogram, it seems pretty complex.
It is. You're talking about needing a really deep knowledge of arterial anatomy.
Knowing all the plumbing,
Right. Plus a huge array of specialized equipment, being ready for potential complications,
knowing what might go wrong.
and having the expertise to tell real findings from, misleading artifacts or errors.
Okay, so it demands a pretty broad and nuanced understanding.
Absolutely. And that's really the goal of this deep dive. We're using chapters from Rutherford's Vascular Surgery and Endovascular Therapy 10th edition as
Ah,
our guide,
the big textbook.
the definitive one, yeah, to sort of pull out the essential knowledge about modern arteriography.
So what are the key areas we're going to explore today? Give us the roadmap.
Okay, we'll start by looking at the pretty extensive range of equipment needed.
Right.
Then we'll delve into the techniques used to actually capture and refine the images.
How it's done.
Yeah. After that, we'll discuss the various clinical situations where arteriography really shines.
Its applications.
Uh-huh. Touch on its limitations and potential risks, which are important.
Definitely.
And finally, take a quick look at where this vital tool might be heading in the future.
Sounds like a solid plan. Let's jump into the equipment first, because just listing it can sound like you need a whole hospital wing for this stuff.
Small chuckle. It can certainly seem that way. But we can break it down. You can sort of categorize it by where the procedure happens, the venue,
Okay.
then the imaging hardware itself.
The machines?
Yeah. The catheters they use to get into the artery.
The little tubes?
Right. The contrast agents, the
Yeah.
stuff that makes the arteries show up.
Like the dye.
Exactly, the dye. Then the devices for injecting that dye. And finally, the digital software that helps process and interpret the images.
Okay, let's start with the venue. It's not just any old room, is it? You mentioned operating rooms, imaging suites, and these hybrid ORs.
Precisely. Where you do, the arteriogram has big logistical implications. You might use a portable C-arm, a fluoroscopy unit you can wheel into a standard OR or a procedure room.
So mobile.
Right. Or you might have a dedicated interventional suite with a fixed imaging unit built in.
Or permanent.
Yeah. And then there are these hybrid operating rooms. They're really interesting because they integrate a fixed high-end imaging system right into a fully equipped surgical environment.
Okay, that sounds like the best of both worlds. What's the big advantage there? Must be expensive.
The key advantage is the seamless transition they allow. You can switch between endovascular, minimally invasive procedures and open surgery.
Without moving the patient.
Exactly. Think about complex aortic endograft procedures, or maybe a common femoral endarterectomy where you find you also need to put in a stent.
Okay.
These combined, or hybrid approaches, along with strategies for things like acute limb ischemia, they're increasingly becoming the standard of care.
Why is that switch so important?
Well, the crucial insight here is if a complication happens during the endovascular part.
Something unexpected.
Yeah. You can immediately pivot to open surgery right there in the same room. It cuts out the delay and the potential risks of transferring a potentially unstable patient.
Ah, so it's about efficiency and safety,
Right.
especially for complex stuff.
That's the core benefit, absolutely.
Makes a lot of sense. Okay, let's move to the imaging hardware itself. Fixed mount versus portable. Beyond mobility, what are the main differences?
Well, both types share the basic parts, right? A generator for the X-rays, the C-arm holding the image intensifier or detector, screens to see the images, and the software.
Got it.
But the fixed mount units, they generally have more powerful generators.
More power means.
It means the X-rays can penetrate denser tissues better, so you get more detailed images, which is a big plus in, say, larger patients.
Okay, better penetration.
Right. Fixed units can also offer much higher resolution. We're talking maybe up to 10 times that of portable units.
10 times, wow.
Yeah, and a much larger field of view. Sometimes modern flat detectors can be up to 22 inches across.
So you can see more at once.
Exactly. Plus, they often have tableside controls for really precise movements of the C-arm and the table. That's invaluable for delicate work like in the visceral arteries or the brain.
Right, fine control.
And like we said, in hybrid ORs, these fixed units are often on a gantry system, a movable frame, so you can position them perfectly or get them out of the way if needed.
That's a huge difference in capability.
Yeah.
So why use portable units at all then?
Well, their main advantage is obvious mobility. You can move them easily between different ORs, procedure rooms, even the ICU.
Flexibility.
Big time. And depending on the setup, you might need fewer staff sometimes, maybe just a tech and the surgeon, though you usually still need a nurse for sedation monitoring.
Right.
And importantly, they're significantly cheaper, both the unit itself and potentially the room construction or modifications needed. Less costly all around.
Okay, clear trade-offs there. Now, catheters, not just simple tubes, you said. Lots of variety.
Absolutely. They come in a huge range of shapes, sizes, length, and they have to match the guide wires you're using.
Okay.
A really key distinction is between end-hole catheters,
Just a hole at the tip.
right, and flush catheters, which have multiple side holes near the tip, plus the end hole.
Why the extra side holes on flush catheters?
They're designed for situations where you need to inject contrast rapidly and evenly into large, high-flow arteries. Think the aorta, the iliac arteries, or even big veins for venography.
To spread the dye out quickly.
Exactly. The multiple holes help disperse the contrast quickly and fill the vessel really uniformly. End-hole catheters, they have more varied tip shapes, often used when you access the artery from further away and need to navigate more selectively.
Got it. Any special precautions with these different types?
Yes, definitely need to be careful, especially using power injection with an end-hole catheter in medium-sized arteries.
How is that?
The high pressure could potentially knock the catheter tip out of position, or worse, create a tear in the artery lining an intimal flap, or even very rarely cause a rupture. And you generally want to avoid power injection altogether into really small arteries, like the vertebral arteries in the neck or the tibial arteries in the lower leg.
So what do you do for those small ones?
For those, a gentle hand injection, either with a manifold system or just a simple syringe, is much safer.
Right, gentle touch for the small vessels.
Yeah.
Okay, moving on to the contrast agents themselves, the stuff that makes things visible. We've got the standard iodinated ones and then the CO2 arteriography. Sounds different.
It is. The basic idea in angiography is creating a difference in radiodensity, how much something blocks X-rays between the contrast and the surrounding tissues.
Okay.
Traditional agents use iodine, which is denser than tissue, so the blood vessels filled with it look darker or opaque on the X-ray image. Carbon dioxide, CO2, is actually less dense than blood.
So it looks different.
Right. It works by temporarily pushing the blood out of the way, creating contrast that way.
Interesting. Let's break down the iodinated ones first. You mentioned ionic versus non-ionic. Sounds like chemistry class.
Small chuckle. It is a bit of chemistry. Ionic agents, when they hit the bloodstream, they break apart, dissociate into charged particles, anions, and cations. The anion carries the iodine.
Okay.
Because they split like that, they create a high concentration of particles, high osmolality, much higher than our blood plasma.
Right.
Non-ionic agents, on the other hand, are designed so the molecule stays whole, it doesn't break apart into ions.
So the osmolality is...
Much lower, about half that of the ionic agents. But critically, they still carry a similar amount of iodine, so they block X-rays just as well.
So similar visibility, lower osmolality. Sounds better.
Generally, yes. It leads to fewer side effects. And then there are even refinements like dimeric ionic agents, which link two iodine structures together. More iodine, still relatively low osmolality, meaning you might use less volume. Table 27.1 in Rutherford's gives a good breakdown of specific agents, their iodine content, osmolality, even cost.
Cost. So are ionic agents still used much if non-ionic seems safer?
They are still used, yeah. Often it comes down to cost. Ionic agents are typically less expensive. You'll see that in the table too. But the trend is definitely towards the lower osmolality non-ionic agents because of that better safety profile regarding reactions.
Makes sense. Now let's talk about carbon dioxide arteriography. Injecting gas into an artery. Is that safe?
It is, when done correctly and in the right situations. The CO2 gas temporarily displaces the blood, giving you the contrast you need.
And why use it?
Its use has really increased, especially for patients with kidney problems, renal compromise, because the standard iodinated contrast can damage the kidneys, what we call nephrotoxicity.
So it's an alternative for kidney patients.
Primarily, yes. And imaging technology, especially digital subtraction angiography or DSA, has made the images you get with CO2 much better than they used to be.
But still not as good as iodinated.
Generally, the image quality, the overall detail, is still considered somewhat inferior to iodinated contrast.
So if the quality might be lower, when exactly would you choose CO2?
The main reason is that high risk of kidney injury from iodinated contrast in patients with poor kidney function, but there are techniques to boost the CO2 image quality.
Like what?
Well, because you're imaging gas, any actual gas in the bowel is a bigger problem, so you try to minimize that. You use higher frame rates when taking the pictures.
Why higher frame rate?
Because the CO2 displaces blood fast and then dissolves pretty quickly. You also often get the catheter tip right into the target vessel selective catheterization and use magnified views to see smaller vessels better.
Okay. How is it injected?
It can be injected rapidly, either by hand or with a power injector. You usually wait a few minutes between injections for the gas to clear out.
Any pitfalls?
One thing to watch for is that you might overestimate how narrow an artery is the stenosis if the CO2 doesn't completely fill the vessel when you take the picture.
Got it. I saw a mention of specific patient positioning for CO2 in the legs. Why do that?
Right. For lower extremity CO2 arteriography, you often put the patient in Trendelenburg, head down, feet up, or just elevate the leg quite a bit.
Why?
It helps slow down the blood flow in the leg arteries. That lets the CO2 gas, which is buoyant, kind of pool or concentrate as it travels down, improving visualization.
Clever. And there's a special delivery system.
Yes, a specific setup. Syringe, special tubing with valves to prevent backflow, a gas bag for the CO2, and the tank itself. And crucially, you have to meticulously purge the whole system of air.
Purge it. Why?
Because room air contains nitrogen, which doesn't dissolve well in blood. Accidentally injecting air could cause a dangerous gas embolism. CO2 is much safer because it dissolves readily.
Okay, very different process.
Yeah.
Now we've got the contrast. How is it actually put into the arteries? Power injectors versus manual injection.
All right. For the best results, you really want the option of using both. They each have distinct advantages depending on the situation.
Tell me about power injectors first.
Power injectors let you inject contrast rapidly at high pressure but with very precise control. You can set the pressure, the total volume, the timing, even how quickly the pressure ramps up.
Why is that control useful?
It's great for quickly filling large arteries with fast blood flow, gets you a nice uniform image. Also useful for longer injections, maybe when your catheter is way up in the aorta, but you want to see the arteries down in the foot. And you have to adjust the settings, right? Higher pressure for big vessels like the aorta, lower pressure and slower rise for smaller ones like the superficial femoral artery to avoid damaging them. You might hear docs talk about 20 for 40. That means 20 milliliters per second for a total of 40 milliliter.
Got it. Any other perks?
A big one is radiation safety. The operator can stand further back from the X-ray source during the power injection, reducing their dose.
Good point. So when is manual injection better?
Manual injection can be done with just a syringe, or more often with a manifold device.
A manifold? What's that?
It's like a control panel with stopcocks. It lets you load the contract precisely, mix it with saline to dilute it if needed, get rid of air bubbles, and even measure the pressure inside the artery in real time. Some systems connect to monitors, too.
Sounds useful. Why dilute the contrast?
Well, even if the patient's kidneys are fine, using less contrast is always good practice. And for smaller arteries, like in the neck or lower leg, carotid, or tibial, often just a few milliliters of diluted contrast, maybe mixed 1-to-1 with saline, gives you excellent pictures.
So less dye needed sometime.
Often, yes. Manifolds are pretty easy to learn to use, and they help you get optimal images with minimal contrast volume. Rutherford's Table 27.2 actually lists typical injection methods, rates, and volumes for different parts of the body.
So it's really about matching the technique to the vessel size, flow, location.
Exactly. Tailoring the approach.
Okay, we've got the contrast in, images are being taken. What happens next? This is where digital subtraction angiography, DSA, comes in, right?
Exactly. Modern arteriography is basically DSA. The core idea is the fluoroscopic image. The live X-ray video is amplified and turned into digital data.
And going digital allows.
It allows for a whole bunch of computer-based tricks, manipulations to significantly boost the image quality.
So it makes the pictures much better.
Dramatically better. It lets us see the vessels much more clearly, often while using less radiation too. That was a huge leap forward.
And these manipulations are the image processing part. What are the key tools here?
Some of the main ones are subtraction and masking, pixel shifting, and view tracing, sometimes called peak opacification.
Yep.
Plus, there are tools like road mapping and unsubtracted referencing that really help guide wires and catheters during interventions. All these processing steps help see fine details better and can also cut down on the contrast and radiation needed.
Let's start with subtraction and masking. You said it's maybe the most impactful feature. How does it work?
Right, so the system takes an X-ray image before any contrast is injected. This is the mask.
A baseline image.
Exactly. Then the computer digitally subtracts everything in that mask, image, bone, soft tissue, whatever is stationary, from all the subsequent images taken after the contrast goes in.
So it removes the background clutter.
Precisely. Since the contrast is moving through the vessels and wasn't there in the mask, it shows up really clearly against the subtracted background. Ideally, only the contrast-filled vessels remain visible.
What's the catch?
The catch is movement. If the patient moves at all between when the mask is taken and when the contrast flows through.
Like breathing.
Or bowel gas moving.
Exactly. Any movement means the background in the later images doesn't perfectly match the mask anymore. So when you subtract, you get artifacts, ghost images, or dark areas that mess up the picture. That's why keeping the patient perfectly still is absolutely critical for good DSA.
Okay. And timing matters too.
Yes, especially if you're injecting far away from where you're imaging. You usually want to start the injection just before you take the mask, so the contrast arrives in the viewing area right after the mask is set.
What if the patient does move? Is the image ruined?
Not always. If movement happens during the contract run, you can sometimes use a different image as the mask. Maybe one taken just before the contrast arrived or one taken after it mostly washed out.
Ah, you can pick a different baseline.
You can try different frames, yeah. See which one gives the cleanest subtraction. It often takes a bit of fiddling.
Okay. What about pixel shifting? Pixel shifting helps when movement happens after the contrast is already there. Instead of needing a whole new mask, you take the original mask and digitally nudge it, shift it, pixel by pixel, up, down, left, or right.
To line it up better.
Exactly. You try to realign the background in the mask with the slightly moved background in the contrast image. This minimizes the motion artifact in the final subtracted picture. Software can do it automatically, or the operator can do it manually using a cursor. Rutherford's figure 27.7 shows this well.
Neat trick. Then there's view tracing, or peak opacification. What's that for?
Well, arteriography is dynamic, right? Contrast flows through over time. A single snapshot might not show the whole vessel filled at its brightest moment.
Some parts might be filling while others are emptying.
Precisely. View tracing lets you digitally stack a series of consecutive images taken as the contrast moves along. The first image shows the start, the next shows it further down, and so on.
So you get a composite image.
Yeah, a composite showing the vessel opacifying over time. It can give a more complete picture. The downside is any motion artifact in the individual frames gets added together, potentially making the final stacked image worse.
So you need clean images to start with.
Ideally, yes. Or you use pixel shifting on each frame before stacking them to minimize the accumulated artifact. After these big steps, you do finer tweaks, contrast, brightness, edge enhancement for sharpness, maybe invert the colors to get the final image perfect for diagnosis and storage.
Sounds like a lot of digital work goes into that final picture.
Mm-hmm.
You also mentioned road mapping and measuring tools, more for the intervention part.
Exactly. Road mapping is really cool. You take a good contrast image you already acquired and overlay it like a faint map on the live X-ray screen you're watching.
A road map for your wires and catheters.
Precisely. It helps guide you to the target. But again, it's super sensitive to movement. If the patient or table shifts, the roadmap becomes inaccurate.
Okay, what about unsubtracted referencing?
That's simpler but useful. You just turn off the subtraction on a stored contrast image. This lets you see the underlying bone landmarks near vessel branches or tricky spots.
So you can relate your tools to the bones.
Right, you might display this unsubtracted view on a separate monitor as a reference while you work on the live subtracted image. Figure 27.9 shows that. And finally, measurement tools.
For measuring stenosis.
Yes, and vessel size. Modern systems have software that can measure accurately. It might auto-calibrate based on distance, or you can calibrate it manually using something of known size in the image, like markers on a catheter. Much more accurate than just eyeballing it.
Incredibly useful tools. Okay, let's talk about imaging bigger areas, like both legs at once. I saw the term bolus chase, or single injection, multiple linear field arteriography. How does that work?
Right, the bolus chase, it lets you image the arteries in both legs all the way down with just one injection of contrast up in the abdominal aorta.
One shot for both legs.
You need a wide image intensifier, usually over 15 inches, to see both legs. Then, after injecting the contrast bolus, the imaging system has to dynamically follow it as it flows down. There are two main ways to do this.
Okay, what are they?
One is the stage technique. The operator presets several overlapping imaging positions or stages from the abdomen down to the feet, maybe 4 or 5 stages.
Okay.
When you start, the machine actually moves upwards first, taking a mask image at each stage. Once it gets the top mask, abdomen, you inject the contrast. Then the machine moves downwards, stage by stage, taking pictures as the contrast flows down, chasing the bolus.
Mask acquisition first, then chase the dye down.
Exactly. Then you process the images from each stage individually, usually viewed subtracted. Figure 27.10 shows this bilateral approach.
What's the other technique?
That's the stepping technique.
Right.
Here, the image intensifier stays still, but the table moves the patient.
The table moves.
Yeah, in small, incremental steps, from the abdomen down to the feet while the contrast is being injected. This lets you follow the leading edge of the contrast very precisely. You can even slow down or pause the table movement if needed.
Have the masks.
After the contrast run is done, the table goes back to the start and repeats the exact same stepping sequence to get the mask images.
Both sound effective. Any downsides to bolus chasing in general?
Yes, a couple of key limitations. First, motion, because the whole process takes longer, maybe around 2 minutes to image both legs.
More time for the patient to move.
Exactly. The risk of motion artifact is significantly higher than for a quick, single-area shot.
Makes sense. What's the other limitation?
It arises if there's a big difference in how blocked the arteries are between the two legs. If one leg has much worse disease, the contrast flows way slower down that side.
So the chase timing gets messed up.
Right. The imaging sequence is usually timed for the faster, less diseased leg, so the really blocked side might not show up well at all. In that case, you'd need to do a separate, one-sided unilateral arteriogram for the bad leg.
Okay. What about contrast dose?
That's another consideration. A bilateral bolus chase might need a fairly large slug of contrast, maybe 80 to 100 milliliters of full-strength stuff. But if you image each leg separately, maybe using a manifold and diluted contrast, you can often get good diagnostic images with less total dye.
So for someone with known bad disease in one leg, separate imaging might be better.
Often, yes. Sequential single-field imaging is frequently preferred in that scenario. Tailor the technique to the patient.
Absolutely. Okay, let's shift to some even more advanced stuff.
Yeah.
Rotational arteriography and 3D fusion CT.
Right. Rotational arteriography is pretty neat. The C-arm rotates around the patient, sometimes almost a full circle, while taking a rapid series of X-ray images during a single contrast injection.
One injection, many angles.
Exactly. Then special software takes all those 2D images and reconstructs them into a full 3D volume.
Like a CT scan almost.
Similar concept, yeah. You get this 3D data set that you can then spin around, look at from any angle, slice through. It gives a much better understanding of complex anatomy than just flat 2D pictures. Figures 27.11 and 27.12 compare single plane and rotational views nicely.
And you can use this for guidance.
Yes, some newer systems have 3D road mapping based on this data. Really helpful for navigating complex areas like during aortic endografting or intricate brain vessel procedures.
Very cool. Now, what about 3D fusion CT? That sounds like combining different scans.
It is, especially with complex endovascular procedures getting more common. Minimizing contrast and radiation is a huge priority. Fusion CT lets you take the patient's preoperative CT, scan their CTA.
The one they had before the procedure.
Right, and overlay it onto the live fluoroscopy images you see during the procedure.
How does that work?
Beforehand, you mark key landmarks on the CTA, like where the kidney arteries come off the aorta. During the procedure, you do a quick rotational spin with the C-arm to get an intraoperative 3D data set. Then software cleverly aligns or fuses the pre-op CTA with the intra-op fluoro images, usually by matching up bones and aortic calcium spots.
So you get the detailed CTA map overlaid on your live view.
Exactly. It acts as a highly detailed 3D roadmap, helping you orient the endograft precisely or find those small target vessels to cannulate. Figure 27.13 shows this.
Benefits.
It takes extra training, but it's been shown to cut down procedure time, radiation dose for everyone, and the amount of contrast needed, especially useful in tricky fenestrated aortic repairs and even some coronary work.
Is it used much in leg arteries?
People are exploring using fusion with pre-op CTA or MRA for peripheral interventions, but the results on consistently reducing contrast and radiation in the legs have been a bit more mixed so far.
What's next for fusion?
Exciting stuff. Maybe tracking catheters without needing constant X-rays, using electromagnetic or fiber optic sensors. Even predicting how vessels might shift or deform during the procedure.
Wow, the future of imaging sounds integrated. Okay, we've covered amazing tech, but let's get practical. How do you actually maximize image quality during the procedure? What are the key factors?
Number one, without a doubt, is limiting patient movement. Absolutely paramount.
How do you manage that?
You have to focus on comfort and anxiety. Pain and nervousness make people fidget. So explain everything clearly beforehand. We often give mild sedatives like midazolam and pain relief like fentanyl before and sometimes during.
Conscious sedation.
Sometimes moderate conscious sedation, yes. But that requires specific certifications, careful monitoring, and dedicated nursing staff.
What about breathing?
Breathing causes huge motion in the chest and abdomen. So we instruct patients to hold their breath during the key image captures. Sometimes a mid-breath hold is best to minimize organ shifting. And for neck imaging, no swallowing or talking.
Got it. Positioning.
Proper positioning of the patient in the C-arm is crucial. Like we said, legs closer for a bolus chase. Some tables tilt, but mostly it's about angling the C-arm, rotating side to side for AP versus oblique fuse, and moving it up, down, or along the table. Table 27.3 gives general starting points for common arteries, but you often have to tweak the angle for each patient and vessel segment. Figures 27.14 and 15 show how changing the angle really helps see things better.
Does the size of the C-arm detector matter?
It does. A larger detector gives a wider view, good for big areas like the abdomen or legs, maybe using less contrast overall. But the trade-off is you might lose some detail on very small vessels or subtle problems.
So how do you see small things?
You use magnification. You electronically zoom in, reducing the field of view to focus tightly on the specific vessel or area you need to see in detail. Figure 27.16 illustrates that.
So it's a combination of patient management, technical skill with the equipment, and knowing the anatomy and tech limitations.
Precisely. It's a multifaceted skill.
Now, with MRA and CTA getting so good, when is arteriography still the go-to, the necessary choice in everyday practice?
That's a great question. You're right. MRA and CTA quality has soared, and they're often the first choice for planning many interventions now.
But not always.
Not always. Arteriography still plays a major role as the primary diagnostic image in many cases, and it definitely remains the gold standard, the benchmark that other tests are compared against.
Okay.
And it's worth remembering, the quality and the information you get from any of these tests, CTA, MRA, or arteriography, can vary. It depends on the physicians reading them, the technologists performing them.
So expertise matters across the board.
Hugely. Which is why vascular surgeons really need to stay skilled at doing and reading high-quality arteriograms, especially for those tricky small vessel areas: foot, hand, gut, pelvis, brain.
And in today's world, trying to be cost-effective.
A good history and physical exam become even more critical. Sometimes they point so strongly towards needing an intervention that you might go straight to diagnostic arteriography, especially if you anticipate needing to do an endovascular treatment right away.
When would you definitely do a CTA or MRA first?
Several scenarios. If the diagnosis is really unclear, and the broader view from CTMR might help avoid an unnecessary arteriogram. Definitely for diagnosing and planning treatment for aneurysms. If you're not sure about the best way to get access into the artery percutaneously, or if you need other info about surrounding organs or tissues.
And arteriography offers more than just pictures, right? You can do things during it.
Absolutely. That's a unique strength. You can measure pressure differences across a blockage to see how significant it really is hemodynamically.
See if it's restricting flow badly.
Right. You can infuse clot-busting drugs or other medications directly into a specific area. You can take blood samples from precise locations, or perform embolization, blocking off vessels to treat bleeding, tumors, or abnormal veins.
So it's a diagnostic and therapeutic platform? I saw our source mentioned conflicting studies comparing it to CTAMRA.
Yes, the literature is a bit mixed on whether CTAMRA are truly equivalent for all situations. Some studies show they're good enough for decision-making, others find limitations.
Like where?
For example, some older studies by Hingarang suggested CTAMRA weren't very accurate for the fine details needed in the leg arteries below the knee, the femoropopliteal and tibial segments compared to arteriography when planning bypasses or interventions there.
But other studies found.
Conversely, some research suggested MRA might actually show tiny tibial vessels that don't show up on arteriography, perhaps because the flow is too slow for the contrast to reach them well on the standard DSA.
So it's complicated.
It is. And many of these studies have limitations, small patient numbers, different methods used. So the bottom line is, the best imaging choice often depends on the specific patient, the specific question being asked, what equipment and expertise are available at that center, and the surgeon's own judgment.
No single right answer. Okay, let's face the downsides. What are the inherent limitations or sources of error with arteriography itself?
Well, we keep coming back to it, but motion artifact is probably the most common and potentially devastating source of error. It can make images really hard or impossible to interpret correctly.
Okay, movement is bad. What else?
Things in the patient's body can get in the way. Bone, bowel gas, old surgical clips, metal implants, shrapnel. Anything dense can obscure the vessel you're trying to see.
How do you deal with that?
Usually by taking pictures from multiple angles or projections, try to look around the obstruction. That's why you almost never rely on just a single straight-on view for important decisions.
What about overlapping vessels?
That's common too, especially where arteries branch or loop around. You get superimposed columns of contrast that can be confusing. The key is recognizing the density difference and again, changing the viewing angle to separate them. Figure 27.17 shows how angling helps clarify a bifurcation.
And the fact that it's a 2D picture of a 3D structure?
That's a fundamental limitation. A single AP view, for instance, can totally miss or underestimate disease that's primarily on the back wall of the artery, like a pancake lesion. It might look minor from the front, but be significant circumferentially.
So you need multiple views.
Absolutely essential. Multiplanar arteriography is crucial to get the true picture. Figure 27.18 has a great example of a stenosis hidden on one view but obvious on another.
Okay, so awareness and technique can mitigate those. What about risks from the contrast agents themselves? The iodinated ones first.
Systemic toxicity, the sort of immediate side effects, are mostly related to that hyperosmolality we talked about.
Higher concentration of particles.
Right. So common things are nausea, maybe vomiting, a feeling of warmth, or even pain where it's injected. These are generally worse with the older high osmolality ionic agents.
And less common with non-ionic.
Much less common and usually milder with the lower osmolality non-ionic agents. That's a big reason they're preferred now.
What about more serious reactions? Allergic-like ones?
Those can happen. They seem related to histamine release. You can get hives, urticaria, which usually responds to antihistamines. More seriously, you might get swelling in the throat, laryngeal edema, or wheezing, bronchospasm.
What do you do then?
That needs faster action. Maybe inhaled drugs like albuterol first, then potentially IV epinephrine if it's severe. And very rarely, a full cardiopulmonary arrest can occur, requiring full resuscitation.
Scary stuff.
It is, but it's rare. It's also important to distinguish these reactions from a simple vagal reaction fainting spell, which can happen from pain or anxiety. That usually involves low blood pressure and slow heart rate, treated with fluids, maybe atropine if severe.
Who's at higher risk for the allergic-like reactions?
Patients with a history of asthma, other allergies, anyone who's had a contrast reaction before, and maybe very anxious patients.
If someone has had a reaction before, can you still give them contrast?
Yes, but with precautions. Pre-medication with corticosteroids is proven to help significantly.
Steroids beforehand.
Right. Common regimens involve giving oral steroids, like methylprednisolone or prednisone, starting maybe 12 or 13 hours before the procedure, sometimes with an antihistamine like diphenhydramine too. Using a low osmolality non-ionic agent along with the pre-medication further reduces the risk.
Does it eliminate the risk completely?
Not entirely. Breakthrough reactions can still happen in a small percentage, maybe up to 10%, even with proper pre-medication, so you still need to be prepared.
Okay. Any risks to the heart or blood?
Contrast can have temporary effects on heart function, especially if injected directly into coronary arteries or the heart itself, mostly due to transient electrolyte shifts. Older agents could sometimes bind calcium and trigger arrhythmias, though that's less common now.
What was the usual effect?
Usually a temporary dip in heart rate and blood pressure, generally minor but can be more pronounced in patients with really bad heart function already, like severe aortic stenosis. Again, low osmolality agents cause fewer of these effects.
And blood effects. Clotting.
Lab studies show iodinated contrast can interfere a bit with clotting factors and platelet function. Red blood cells can also clump together slightly in contrast. While the real-world impact isn't totally clear, it's why we're careful to flush catheters and sheaths frequently with heparinized saline during procedures to prevent clots forming inside them.
Do you give heparin to the patient routinely?
Systemic heparinization is decided case by case, depending on the procedure and patient risk. If used, you monitor it with ACT levels and can reverse it with protamine afterwards. Non-ionic agents might have slightly less impact on coagulation too.
Okay. Now, the big one, kidney damage.
Mm-hmm.
Contrast-induced nephropathy, CIN. How common and serious is it?
It's a major concern. CIN is actually the third leading cause of acute kidney failure that develops in the hospital. It can range from just a small temporary bump in creatinine levels to severe kidney injury needing dialysis, and it can increase morbidity and mortality.
Who's most at risk?
The single biggest risk factor is having pre-existing kidney dysfunction before the contrast. Other risks include older age, heart failure, dehydration, diabetes, especially if they already have some kidney issues and maybe high protein in the urine.
So for high-risk patients.
You absolutely minimize the contrast volume used and make sure they are very well hydrated before and after.
Does the type or amount of contrast matter if your kidneys are normal to start?
Interestingly, for patients with normal baseline kidney function, studies suggest neither the type ionic versus non-ionic nor the total volume really seems to significantly change the risk of CIN.
What if someone's already on dialysis?
Well, the contrast can't damage their kidneys further, obviously, but they can still get fluid overload from the osmotic effect of the contrast, so they often need dialysis soon after the procedure anyway.
How does contrast actually damage the kidney?
It's thought to be a combination of direct toxic effects on the kidney tubule cells and also causing temporary ischemia, reduced blood flow within the kidney.
How does it reduce blood flow?
The high osmolality draws fluid into the tubules, increasing pressure. This can trigger constriction of the small arteries feeding the kidney filters, glomeruli, reducing filtration rate and blood flow, leading to ischemia.
What's the incidence?
In people with normal kidneys, it's low, maybe 1–2%, but it climbs steeply if you already have kidney disease. If your creatinine is over 2 mg/dL, the risk might be over 60%.
What about diabetics?
Diabetics are at higher risk overall, likely because they often have underlying kidney problems, even if not diagnosed yet. But diabetes itself, without existing kidney dysfunction, doesn't seem to be an independent risk factor. Type 1 diabetics might be slightly more prone than type 2, and if a diabetic with kidney problems does get CIN, their prognosis is often worse, less likely to recover kidney function, higher risk of needing long-term dialysis.
Okay. What about patients taking metformin for diabetes? Special consideration.
Yes, very important. Metformin is cleared by the kidneys. If a patient taking it develops kidney failure, like CIN, the metformin could build up and rarely cause a serious condition called lactic acidosis.
So what's the protocol?
Guidelines have evolved, but generally recommend use only low osmolality contrast. Check kidney function before and after. If kidney function is normal, usually just withhold metformin for 48 hours after the procedure.
What if they already have kidney problems?
If they have stable baseline renal insufficiency, the usual advice is withhold metformin for 48 hours before and 48 hours after.
And in an emergency?
If an emergency contrast study is needed in someone with kidney issues on metformin, you proceed but hydrate them really well afterwards for at least 24 hours and watch very closely for signs of lactic acidosis, nausea, vomiting, fatigue, abdominal pain, thirst, specific lab changes like low pH and high lactate.
Okay, careful management is key. So how do we prevent CIN in those at risk? What actually works?
The most consistent evidence supports intravenous hydration. Giving IV fluids, typically normal saline, lower 0.9% sodium chloride, both before and after the contrast, seems to be the most effective strategy.
What about baking soda? Sodium bicarbonate.
There was some thought that bicarbonate might be better than saline, and some early studies suggested a benefit. But recent, large, well-done trials like Amazing and Preserve failed to show it was any better than just using normal saline. So saline hydration remains the standard.
And N-acetylcysteine, NEC, that gets mentioned a lot.
Yeah, NEC is an antioxidant. Some smaller, earlier trials suggested it might offer protection, especially in patients with kidney dysfunction. But again, the big recent trials like Preserve and others haven't confirmed this benefit. So its routine use is pretty controversial now. Most guidelines don't strongly recommend it.
Any other drugs?
Lots of other drugs have been tried, things to open up blood vessels, diuretics, etc. Phenoldiprem, theophylline, prostaglandins, calcium channel blockers, dopamine. But based on the current evidence, none of them can be routinely recommended for CIN prevention.
So it really comes back to basics.
Pretty much. Strict protocols emphasizing using the absolute minimum contrast dose necessary for diagnosis, combined with aggressive IV saline hydration for at-risk patients, those seem to be the most reliable strategies. And that applies whether it's for an arteriogram or even just a contrast CT scan.
Got it. Hydration and minimize the dose. Now, quickly, any specific risks with CO2 contrast besides the image quality issues?
Yes. We mentioned visualizing posterior vessels can be tricky in the supine position. Elevating the flank or tilting the table helps. Newer software like DDA improves image quality too.
Complications.
They're rare. There are some case reports of bowel ischemia, maybe from gas getting trapped in mesenteric arteries. But the biggest concern is neurotoxicity.
Brain issues.
Animal studies showed injecting CO2 directly into carotid arteries could cause strokes. Because of that risk, the strong recommendation is not to use CO2 contrast above the level of the diaphragm.
Crucial safety point. Okay, we have covered a huge amount today. Equipment, techniques, uses, limitations, risks. As we wrap up this deep dive, what's the future look like for arteriography?
Well, despite all the advances elsewhere, arteriography is still absolutely essential for vascular surgery, and its future looks bright, actually.
How so?
We'll likely see even more integration with other imaging types, leading to better pictures, more physiological data alongside the anatomy, and more precise ways to deliver targeted therapies. Innovation isn't stopping.
So it keeps evolving.
Definitely. But that means having a really strong foundation in education and training in arteriography and a commitment to keeping up with modernization is going to be absolutely crucial for vascular surgeons moving forward.
So it's clear, arteriography isn't going away. Even with amazing non-invasive tools, it remains vital. We've hit on the equipment choices, the different techniques for different jobs, that unique link between diagnosis and treatment, and the critical need to understand the limitations and risks, especially with contrast.
Indeed, it's a complex but powerful tool.
And it's constantly evolving, with exciting potential for blending with other technologies. So as we finish this deep dive, here's something for you, our listener, to think about. In this landscape of rapid technological change and intense focus on patient safety, how do you see the balance shifting between invasive arteriography and non-invasive imaging in the coming years? What aspects of our discussion today maybe surprised you or seemed most relevant to how you think about medical imaging?
A great question to ponder.
Thank you for joining us for this in-depth exploration on the deep dive.